many different Asian countries. And here is some of the snapshots. And we're not just providing the lectures, but also some hands-on workshops. We so focused on the hands-on workshop and also the well-designed protocol on the training. Of course, in the era of the right now, we are facing a COVID pandemic around the world, not just the Asia. So right now we will host the hands-on workshop, but we still continuing the education by means of Zoom or online meeting, just like exactly this one, with some collaboration with the local urological association, so that we can provide educations continuously without affected by the COVID pandemic. And if you're very interested, I think the newer generations were more familiar with the website or the Facebook or Twitters. If you are interested, do take a look at our online promotions, campaigns, and Twitters, everything. Do take a look and see what we can provide for you for your training. That's the end of the introduction of the OSTEC, and thank you very much.
Thank you for your excellent introduction, Dr. Chan. And to continue, I want to tell you that today's meeting is about the lower urinary tract procedures. And now let's start with the first lecture, with the title is Bipolar Technology, an update on lower urinary tract procedures, presented by Dr. Lukman Hakim. Please.
Yes, good afternoon, everyone. I think we have a similar time in our countries. So this must be afternoon also in Hong Kong. First of all, I would like to thank OSTEC, Eddie, and all our friends in OSTEC. Also to Professor Finn and Dr. Huang for having me involved in this prestigious meeting. My talk today will be about the bipolar technology update. May I share my slides, please? Just a minute. Okay, there seems to be a little bit problem here. Just a minute. Yeah. So can you see my slide?
Yeah.
Okay, Dr. Huang, I would like to apologize for not using the background that you have given me. I tried to use that, but it seems that my laptop cannot take some of the colors, I guess.
Not important, not important.
Okay, thank you very much. So this way you can better see my face. So my talk today will be about the bipolar technology, an update on lower urinary tract procedures. I would like to start with a simple slide mentioning about the history of electrosurgical technology for endourological purposes. So it started, the monopolar technology was invented in 1983 in Japan. And this was the time that we used a monopolar electrosurgical device for TURP. And then about a couple of years later, the Lithulium Laser enucleation of the prostate was invented. And then this was also the decade where morcellator was developed for the first time, and the technique of morcellation following HoLEP was also introduced. And then we come to the decade of 2000s, where bipolar or plasma kinetic was invented. A couple of years later, the first randomized clinical trial comparing different sources of laser energy for the enucleation of the prostate was performed. And in the 2010s, various comparative study, randomized clinical trial using different TURP techniques and also electrosurgical devices were conducted. And then we have also newer type of laser, not only holmium, but even thulium in this case. And then we also have some combination of these techniques, such as a combination of enucleation and vaporization. So basically, the TURP, the transurethral resection of the prostate, is currently still the gold standard if we refer to the major guidelines. This is an endoscopic approach. I believe that all our participants today from Vietnam are aware of it. And there are several issues to be considered. Of course, post-operative care is important in this case, and also consequences using the TURP technology. We also have early morbidities that has taken into account. And then there is also a small proportion of re-surgery using this technique. Now, in this slide, I would basically emphasize again the difference between our monopolar, the first invented electrosurgical technology that we have used, compared to the newer technology, which is bipolar. If you see on the right side, basically the monopolar electrosurgical device used a higher voltage and constitute a higher energy. That's the basic difference of monopolar and bipolar. As a consequence of this, the electrosurgical current travels from the generator, from the device, to the electrode, and then to the tissue, and then to the patient through its PHet, and then back to the generator again. This somehow may have some consequences, minor consequences, which may happen, although in a very low proportion. And then the other consequences of using monopolar is there can be more surrounding tissue damage as a consequence of using higher voltage and energy. However, the advantage of monopolar electrosurgical device, it has superior cutting ability and to coagulate the tissue. While the bipolar has everything conversely. It uses lower voltage and energy and triggered a temperature surrounding the tissue of less than 70 degrees Celsius. If we compare to monopolar, it can be 300 to 400 degrees Celsius. And then the main advantage is that the electrosurgical current is limited between the forceps. As we see here, there are no PHets that is used. And this also means that the minor problem of using PHet, such as skin burn, can also be omitted. Thus, in conclusion, basically the bipolar technology may prevent surrounding tissue damage, not as monopolar, as a consequence of lower technology, lower voltage and energy. But however, it has limited ability to cut and coagulate bleeding areas, particularly large bleeding vessels compared to monopolar. So basically, in summary, we have four at least areas where monopolar and bipolar electrosurgical devices may be applied in urology surgical techniques. First, as we know, is the prostate resection or the bladder neck incision. And then we also have the ejaculatory duct resection. This is basically the same using electrosurgical device. And then, of course, we have the bladder tumor resection, TURBT, and also the new technique called en bloc resection of the bladder tumor. And lastly, in children, we can also use the electrosurgical device with a special loop for fulguration and resection of posterior urethral valve, which may cause vesico-urethral reflux. Now, this slide will summarize all the application of technology for minimal invasive surgery in a benign prostate obstruction. As we see here, we have the what we call the non-laser technology using either monopolar or bipolar. We also have the laser technology using different sources of laser. And we also have other minimal invasive surgery using stents and urethral lift for BPO. Techniques also differs. We have the resection, which is the basic technique. We also have vaporization, we have enucleation, and a combination of both, which is called as vapo-enucleation. The procedure, we may also use the monopolar for resection, monopolar for vaporization, although not ideal. But on the other hand, we also can use bipolar for resection, vaporization, and vapo-enucleation. And also in the field of laser, we can use it for either enucleation, vaporization, or a combination of both. Now, what we need basically for the for enucleation, resection, or vaporization is first the electrocoagulation device. Here we can use a monopolar or bipolar, which of course have different specification. The bipolar device is usually high frequency, and then we also need resectoscope and its electrode. And the resectoscope or electrode is different between the monopolar or bipolar device. And third is the irrigant. We can use the distilled water, the saline, or the glycine for surgery. Now, the so-called transurethral resection in saline, or on the other hand, it's also called as bipolar TURP, is basically, as I mentioned earlier, constituting a very low temperature surrounding the area, less than 70 degrees Celsius, compared to monopolar, which may trigger 300 to 400 degrees Celsius. This is very important because the surrounding tissue damage can be much prevented using the bipolar technology compared to monopolar. This is just an example where a mushroom-shaped button as an electrode can be used for vaporization and enucleation using the bipolar electrosurgical device. I'm very sure that the rest of the speakers today will show you a demonstration of live surgery using this electrode using bipolar technology. And then we have, this is the invented by Olympus. On the other hand, we also have some electrode using bipolar electrosurgical device with specific electrode that can be used for either bladder neck incision, resection, or vaporization, as well as enucleation by Karl Storz. Now, this slide, I just want to show all of you a simple video where bipolar technology can be used with different techniques. On the left, we can see the vaporization technique using the mushroom button electrode by Olympus. On the middle part, you can see the bipolar transurethral vaporization using Storz electrode. And on the right side, you can also see the transurethral enucleation, or sometimes also called as vapo-enucleation of the prostate. The right side is actually the latest, one of the latest technology or technique that was invented, where mimics actually the principle of open prostatectomy procedure. It basically tried to find a space where there's the disruption, maybe at his step-by-step push the adenoma until finally all the adenoma can be enucleated. Okay. Now, there are four factors that needs to be considered in resecting the prostate in general. First is the energy that travels. As I have mentioned earlier, the benefit of bipolar compared to monopolar, and then the bleed, and then the irrigant that has that will be used, and last is the thermal effect for the surrounding tissue. These four factors may cause perioperative, short-term, mid-term, and long-term complications. And these are basically the summary of complications that might occur from the local burn of the skin. This is usually when we use monopolar device due to the pad. And then we can also have post-operative transfusion. And one of the most important thing is the TUR syndrome, which is quite common when we use the monopolar technology, stenosis, ejaculatory tract stenosis, and so on. So what does the guidelines say about surgical technique for benign prostate obstruction? If we refer to the European Association Urology guideline here, basically for BPO with a size of between 30 to 80 ml, there are some options starting from TURP, which is put or written in bracket as 1, and this means as the standard of care. TURP is the standard of care for 30 to 80 ml size of prostate. And then, but other techniques and technology can also be applied, such as laser enucleation, bipolar enucleation, and so on. And then if we see big prostate more than 80 ml, the standard of care, according to the guideline, is either open prostatectomy, holmium laser enucleation of the prostate, or bipolar enucleation of the prostate. And then, of course, if the patient consume anticoagulant or antiplatelet therapy, and these drugs cannot be omitted, so the guideline only refer to two recommendations actually, either laser vaporization or laser enucleation. So now the question, bipolar or monopolar? Monopolar TURP, bipolar TURP, or bipolar vaporization of the prostate? I will just summarize what the guidelines say about this. So the bipolar resection of the prostate achieves short, mid, and long-term results comparable to monopolar TURP, but with one minor advantage, which is more favorable in perioperative safety profile. So it depends on us urologists. The efficacy of both bipolar and monopolar are basically the same, similar in the short, mid, and long-term results. Second is the bipolar vaporization of the prostate and resection of the prostate have similar short-term efficacy. Plasma kinetic bipolar vaporization has a favorable perioperative profile, similar mid-term safety, but inferior in mid-term efficacy compared to bipolar TURP. Plasma kinetic bipolar vaporization has a lower short-term major morbidity rate compared to bipolar TURP. So this actually emphasizes in general either bipolar TURP has somehow advantage compared to other techniques with different energy sources. So I would like to mention again that only vaporization and enucleation of the prostate using laser energy are currently recommended for patients on anticoagulant treatment. So in my last slide, I would like to conclude that, again, the current gold standard for surgical treatment of BPO is TURP. And then the bipolar technology offers some advantages to monopolar, but the long-term efficacy of bipolar TURP and compared to bipolar vaporization are still awaited. The efficacy of a short and midterm are similar, but the long-term efficacy, I think that we need to wait for a bit longer for the RCT that compare both procedures. I'd like to thank all your attention, and I'll be happy to answer some questions. Thank you.
Thank you for your excellent presentation. And now I want to hear some opinion of the attendee.
Can you still hear me?
Yeah.
Yes, I think I have one difficult problem here. I cannot share my slide. Okay, please ask some questions if there are any, while waiting for my laptop to stop the sharing.
If nobody has anything else to add, we can continue to the next lecture. The next lecture is BPH, transurethral bipolar enucleation, vaporization, and resection will be presented by Dr. Sung-Yong Cho. Please start, Dr. Cho.
Hi, good afternoon, everyone. Thank you for your kind introduction, and I'm so honored to be here. Can you hear me?
Can hear you very well.
Okay, thank you. So it's my honor to be here with you, and today my topic is about transurethral bipolar inoculation, vaporization, and resection. In Korea, in the 1980s, actually the prevalence of BPH was only 8% at that time, according to the nationwide inpatient data. Of course, this is the limitation because it is limited only in inpatient data. But after this time, the number of BPH patients increased because the Korean society was becoming an aging society and decrease of birth rate. So the number of patients with medication increased actually. So while the medication increased, the number of TURP decreased at that time. But according to the feature of the aging society, the prevalence of LUTS is gradually increased, and the severity of LUTS, according to the IPSS scores, also increased, like as shown in this figure. So we can expect the poor quality of life according to the severe LUTS in this aging society. So the diagnostic algorithm has become more important recently. So if the patients with lower urinary tract symptoms visited our hospitals, we normally check the physical examination, including the rectal exam, and we normally add urinalysis and serum PSA to exclude some inflammation or prostate cancer. And after we evaluate the bothersomeness of lower urinary tract symptom, the first thing we normally do is to differentiate the presence of nocturia, because basically the surgical outcomes for this nocturia is just about 50%. So if the patient don't have any polyuria, then normally nocturnal polyuria, that we can try some medication first, such as alpha blocker or 5-ARIs. But if it is not so effective, then the urologist can evaluate more checkups, such as uroflowmetry or the residual urine volume and some other factors related to the overactive bladder symptoms. So if there is any evidence of bladder outlet obstruction, we can think of some medications like 5-ARI, or we can check, of course, the prostate ultrasonography. And finally, we can consider the necessity of performing prostate surgery. So recently in Korea, we can check the trend of BPH surgery. And as you see in this figure, the proportion of TURP, including bipolar, and HOLAP, holmium inoculation of prostate, increased during the last decade. So many people, of course, while I was a resident, I learned how I can perform TURP, the resection of prostate from inner side to outside. But recently, I don't normally do TURP, because after I learned how I can do the inoculation procedure, and many urologists started to realize that the feeding vessels normally are located in the area between 1 to 5 o'clock and between 7 to 11 o'clock, just next to the vermontanum area. So if we can control these feeding vessels just next to the area just next to the verimontanum, we can see very clear operative field while we do the routine inoculation procedure. So we have several options to do this, especially bipolar inoculation. And of course, I skipped some slides about the many energy modalities to if we want to do the inoculation procedure. But anyway, today I focus on the bipolar inoculation. And of course, even we consider bipolar inoculation, we have several options like this, as shown in this slides. So normally we can we already are familiar with this type of cutting loop, and we have some different size of cutting loops, like as you can see here. And so normally, if we want to use the electro cutting loop for inoculation, we have to use smaller type because the inoculation space is not so big. Basic movement of inoculation, even we want to use bipolar, it's the same with the laser inoculation. So there's a left side figure. Left side of figure is that is taken while I did the inoculation procedure, bipolar inoculation, and the right side is while I use the holmium laser fiber. So the left side hand should be fixed with while we grab the video camera head, and only we can use the swing move. The right we need to do the swing movement while we grab the scope with our right hand. And basically, we have to imagine the spherical structure of the prostate area, because the verimontanum area and bladder neck area is quite narrow, and the normally enlarged prostate nodule occupies like this like a barrel inside the prostate fossa. And while we do the inoculation procedure from medial to the lateral side, sometimes we forget the shape of the barrel in the prostate fossa. So we need to go to the central side to focus on the round shape of the bladder neck. So if we forget that, sometimes we can see some prostate fossa perforation and some irrigation fluid leak outside the prostate fossa. So basically, the first thing I normally do for inoculation is the identification of the location of the urethral orifice. So sometimes the urethral orifice is quite close to the bladder neck, and while I do the inoculation procedures, we can make some damage to this urethral orifice. And if there is a huge IPP, namely intra prostatic protrusion, I mean, into the bladder, if there is a huge nodule inside the bladder, and then the distance from this prostate nodule to the orifice can be quite close. Then what we do while we do the inoculation procedure just around the bladder neck, we can undermine the mucosa to the urethral orifice, and we can make some urethral orifice damage. So if there is a huge IPP, then the first thing I strongly recommend, the first thing to do is the bladder neck incision. And just when we do the inoculation, just the area around the bladder neck, then we can easily see the already cut mucosa, and just if you can reduce the risk of urethral orifice injury. So I summarized the step-by-step procedure of bipolar inoculation recently in the Andrologia journal, and there are some controversial points about the procedure of inoculation, such as tissue and management of tissue in 12 o'clock, dissection near sphincter, how to handle a scope, and the prostatic mucosa detachment. So as I mentioned earlier, the first thing that I strongly recommend is only mucosa incision, and the incision should be quite deep if can see the effect of this mucosa incision. So we need to we can use the electrode cutting loop, or we can use some different kinds of electrode. Anyway, we can make an incision at the bladder neck level, and then we can move to the verumontanum level to make an incision just next to this verumontanum. So the first incision site is normally at 5 o'clock and 7 o'clock. Like as you can see the figure. And then, of course, we can consider three lobe technique or en bloc one lobe technique together. But if you think you are beginners, then I recommend the 3 lobe technique first in your practice. And for the three lobe techniques, the first thing is to remove the median lobe. So we can make some 2 incisions that's lateral to the median lobe like this, as you can see the first figure. And then we can make the transverse incision just above the verumontanum level, and we can make a inoculation plane just beneath, just under the median lobe. So that is because if we remove the median lobe first, then we can get enough space for irrigation fluid, and if the irrigation is quite good, then we can see very clearly the prostate nodules, and even if even there is any hematuria. And especially this is very effective if the median lobe is very big. But of course, I think for the lateral side incision of medial lobe, I think the laser fiber is more effective than because if we use some bipolar electrode, the thickness is much broader, much thicker than laser fiber. So of course, if we want to do the median lobe inoculation first, the laser fiber can be more easy, but of course I think the median bipolar electrode top is also effective for doing the median lobe inoculation first. And then we can, as you see, I described some procedures of median lobe inoculation in this slide, and I already mentioned about this. So the median lobe first, median lobe can be resected first, and then normally we normally do the inoculation for our predominant hand side. So normally I do the patient's left side, left lateral lobe inoculation. I normally do first. So yeah, this slide is about lateral lobe inoculation, and the most important thing we should keep in mind is the swing movement from median to the lateral direction is important. So basically, we should not the direct back and forth movement while we do the inoculation procedure. So if of course, we need to go forward during inoculation procedure, but if we think the forward movement, normally it makes the perforation to the prostate capsule. So if we do the swing movement from medial to the lateral side, it makes forward movement as well. So you should not think, of course, the only forward movement can make some space for inoculation, but just swing movement is enough to enough space for on the inoculation plane. And while we do the lateral side inoculation, normally the electrode can be, or the prostate nodule can be stopped at around 3 o'clock area, and it's time for us to make the second mucosal incision, or it's time for us to move to the 12 o'clock side to make an inoculation plane. So at that time, I normally do the vaporization vaporization of tissue at 12 o'clock first, and it is helpful to make the prostate lateral side nodule move freely. So if we do manipulate, or if we do the vaporization at 12 o'clock first, and then we can make some inoculation plane or mucosa incision at around 12 o'clock, and we can see the meeting point of mucosal incision site. So, and just at this time, the lateral side prostate nodule can be very free to remove. So some guys make the three sides incision, as you can see the left side figure, and so the first incision can be done just next to the verimontanum, and the second incision can be made from 2 to 5 o'clock, and the third incision can be made from 12 to 2 o'clock. So for example, Cesare Scafone, Marco Scafone in Italy normally explain the three sides incision, as you can see this figure, but some other guys, some other urologists explain the straightforward incision from 12 to 5 o'clock, as you can see the right side figure. So, but the basic concept is the same. So we need to incise the bladder mucosa from 12 o'clock to the 5 o'clock. So if there is any remnant part of the intact bladder mucosa, then it can make some sphincter injury or traction of this traction of the mucosa, and finally it can make the sphincter injury. Sorry, my premise. So as you can see, the first mucosa incision, you can see some details of this three sides incision. So if there is a sphincter just next to if there's a sphincter and it is quite close to the verimontanum, and we have to make the first mucosa incision above the sphincter level, and we can consider next the second mucosa incision. That is the point connected to the end of the first mucosa incision. So this is about the progressive cutting of the apical mucosa and the lateral side of the lateral lobe of the prostate. And then just if the bladder mucosa or around the prostate nodule is free, then we just need to push the nodule, and we can see some mucosal area with much blood vessels, creeping vessels. And the only thing we need to do is just coagulation of this creeping vessels or end vessels as well. So after we finish the coagulation of these vessels and push the nodules and coagulation again, the repetitive actions can be necessary until the end of this inoculation of the lateral side prostate nodules. And if we can see some remnant adenomas in the inoculation plane, we don't need to worry. And sometimes we want to try to undermine the satellite nodules, but sometimes it can make some prostate capsule perforations. So normally I do the vaporization of the satellite nodules if I think there is any risk of prostate capsule perforation, and it is quite effective to maintain the clear inoculation plane. And of course, after we finish the inoculation procedure in the lateral side, and we can see some remnant adenomas around the corners, then just we can easily remove the remnant adenoma, and we can vaporize all of them. So we can make some clear plane. And after I finish the left-sided inoculation procedure, then I move to the right side. And the procedure are almost the same with the lateral side inoculation, but just but a little minor difference is about because I am right hand predominant, so the posture can be a little weird. So the mucosa incision can be just a little different, but the basic concept is the same, and the basic principle we should keep in mind is that the bladder mucosa just around the prostate nodule should be cut before we do the enucleation, before we push the prostate nodule. So if we push the prostate nodule with some remnant bladder neck, bladder mucosa inside the mucosa, remnant mucosa can make some traction to the sphincter. So just sphincter injury can be problematic during post-operative period. So of course there are some controversial points how to manage the anterior, I mean the 12 o'clock area of the prostate, and there are three kinds of methods to how to manage this anterior lobe. So the first thing, and this is my preference, is the vaporization. And I think the bipolar electrode can be more easy to handle compared to the holmium laser. And if you want to do the enucleation in the anterior side, or then bipolar or whole lab has shown no difference about this. And some guys think the anterior part in prostate nodule is not so big, or we don't normally meet this big prostate and in the anterior lobe, then just we can leave as it is. So in this case, then bipolar or holmium laser enucleation cannot show any significant difference in the procedure. So if we want to do some anterior part enucleation, we can see some the mucosa muscular layer. So this I mean that we can, this part is quite easy, fragile, so sometimes fragile, so we can see some disrupt of this mucosa layer, so it can make some significant bleeding. So I agree to the opinion that some urologists will try to leave the anterior part as it is. So of course it is still controversial. I think this is the part of surgeon's preference. And after we remove all the prostate nodules, then just we can remove the remnant adenomas, or we can leave them, so without any without doing anything to them. So just the mucilation procedure can be done after we finish the enucleation procedure. But before we do the mucilation procedure, the bleeding control should be perfect, because if there is much bleeding, then the vision would not be so clear, and sometimes we can mucilate some bladder tissues together, because we cannot see the resected prostate nodule clearly. So the bleeding control, we need to spend 5 to 15 minutes. Of course, the time is not so important anyway. So the bleeding control should be perfect before we do the mucilation procedure. So I want to wrap. This is my take-home message, and the first thing is the bipolar electrode is a quite feasible way to do the enucleation according to my experience. And then yeah, as I show you the picture of the scope, the 90-degree camera head is much convenient for enucleation than the straight type. And bladder neck incision in the early part of the enucleation procedure, it can be quite helpful to demarcate the bladder neck area to avoid any ureteral orifice injury while we undermine the bladder mucosa. And for safety concern, we always have to keep in mind that the prostate fossa is quite spherical, shape is quite spherical, and we need to centralize the direction to the bladder neck area. So thank you for your attention, and just so yeah, please give me any comments or questions today. Thank you.
Thank you, Dr. Yong Cho. Now we have many questions for you. One question ask in Korea, what is the percentage of operated lots BPOs now?
Basically, just 5,000 cases, 5 to 10,000 cases we normally do, and the surgical rate is not so high, less than 10%, around 10%, I think.
Yeah.
Dr. Joe, that's my question.
Yes.
Because I asked you this question because in recent year, when we try to train or to study new transurethral technique for lux BPH, we had the problem of recruiting the patient, because most of my patients who see me at the outpatient, I give them the medications, and they have a big amelioration in IPSS and quality of life, so that the percentage of my operated patient, I think, is about 3 or 5%. So when I try to study the new technique, for example, the Bpo lab or the 2 lab or the whole lab, we try to ask the whole institution to recruit the patient at the outpatient department to have the number of operations. And sometimes it took us a long time to have enough patients to fulfill the learning curve. And so that's why I asked you this question.
The learning curve, in terms of learning curve, many people agree to the opinion that holmium laser enucleation can be quite steep, right? So bipolar or monopolar can be quite familiar with urologists, because we are we learned with these devices from our residence period. So basically, if we are not good at doing the enucleation procedure while we use the monopolar or bipolar device, then we can do the resection, I mean the TURP, conventional TURP. But just the learning curve, if we see the many cases of enucleation procedure, the basic principle of enucleation plane, how to make the enucleation, or how can start the how we can find the initial part of the enucleation plate is the same. So the learning curve can be quite minimal. So I think it is a matter of experience, and I think if there is any good mentor just around us, then just the mentor can give a very critical points explanation to the beginners. So, well, the learning curve, there are so many factors to affect this, the learning curve. So I cannot say, well, just definite things to you, but I think the bipolar is quite easy to learn and to overcome the learning curve. And if it is not so, it's not so easy for beginners to do that, and just we can combine the conventional TURP procedure and the enucleation procedure, so we can get some time for our patients without any safety issues. But And another problem is the price, maybe. And bipolar device is quite relatively cheap, compared to the laser machine. So we can have some more opportunities to use and to get some more experience using for the use of bipolar device. So, well, with many reasons, I can recommend the use of bipolar device for prostate surgery anyway. And I think when you consider the recurrence rate, low recurrence rate, then inoculation procedures can be absolutely helpful than the conventional inner side resection of prostate. And another point is the indications of prostate surgery. So many patients complain some storage symptom or nocturia, and the recent the evidence until now has shown that but prostate surgery is not so good at the minimizing the relieving storage symptom or nocturia. So we have to select the good patients for the prostate surgery, because then we have to give some explanations to our patients. The prostate size is not the critical factor to decide the necessity of prostate surgery.
Thank you.
Thank you.
Dr. Cho,
yes,
there is some question for you. One question is, do you think the remnant adenoma should be vapor rather than resection? Because I think that is more easy. And this doctor said that he just started doing enucleation for BPO recently, but he revealed that the morcellation phase takes too long, nearly half of the operation time, and he wants you to give him some advice.
Yeah, thank you for your question. And I think the remnant adenoma, normally I do the vaporization because, and of course for satellite nodules or remnant adenomas, I normally do the vaporization for this, because we can get a clear inoculation plane, and of course there can be some chance of prostate cancer in these remnant adenomas or satellite nodules, but the chance of prostate cancer can be minimal. So I normally vaporize these tissues. And if we do the inoculation for this remnant adenomas, then these tissues can float here and there, and just sometimes it can block our camera field. So it can be quite bothersome. So I normally do the vaporization for this. And if you think the morcellation time is quite long, then just before you start the inoculation procedure, we can make some deep incision into the prostate nodules, and more incisions you make, then easier the procedure can be, because the round shape hard nodules, it is quite difficult to do the morcellation. So if you make some deep incisions here and there in the prostate, especially if you think this tissue is quite big, and if the prostate size is quite big, then just this incision can be very important to shorten the morcellation time.
Dear all, so now I have many questions, but I think we will come back to the questions after finishing all the in the discussion.
Yes, thank you.
Yes. And we can continue to the next lecture is bladder tumor, NBI application and transurethral bipolar resection, presented by Dr. D. Chan. Please start, Dr. Chan.
Okay, thank you very much. I'm Dr. Chen. Today I will talk about the bladder tumor, the narrowband imaging, and transurethral bipolar resection. And in the first part of it will be the narrowband imaging. I think it is nothing new to many of urologists, but whether we applied it or not is another issue. Today I will talk about something on the narrowband imaging as well. And before it make it possible to using the narrowband imaging, we need to have a very good flexible cystoscope or endoscope. In this era, we have the video scope, means that as compared, let's say 15 years ago, we're still using our own eye to take a look inside or just clip a camera onto the back of the scope. Right now, we have the video chips right at the front, and also with a way better light source, much brighter and better light source, so we can make it narrowband imaging possible. And as I said, this is nothing new, and it's first reported in Japan, and initially it is rather used in a transparent kind of a tissue, just like using in the eye or the ophthalmologist. But afterwards, they used this narrowband imaging in the endoscopic structure. It has uniqueness that we don't need to inject any intravenous or intravesical agents to show the contrast or show the structures. The theory behind the narrowband imaging is by using the differential penetrations of the light by using different kind of wavelength. With let's say the blue light can only penetrate superficially, whereas the long wavelength red light can penetrate deeper, so that we can have almost like dissecting the structures when we're doing the cystoscope. And here is a more graphical kind of representation. And in the narrowband imaging, we're mainly using the blue-green kind of wavelength. Means that instead, as compared to using the whole white light spectrum, we're just taking a 2-band or narrow band of the whole spectrum only, so that we can see the contrast as compared to each other. It's almost like when we're doing the astronomy, when we are looking in the sky and then doing deep sky object is the lapilla. When we're using the narrow band, means that we're dissecting the whole lapilla with a different wavelength, then we can really go deep into it and show a completely different picture with a way better contrast. Narrowband imaging firstly use the endoscope is mainly in the upper GI or lower GI tract, just like in the coloscopy or Barrett esophagus. Right now, they're still commonly used in by the general surgeons. When they're doing the endoscopy to look for any abnormal vessels, to show any subtle abnormalities or even early stage cancer in the gastrointestinal tract. And for the urologist, the applications of narrowband imaging in the bladder can date back to year 2007, and means that's more than 13 years ago. And it is the very first paper that's publishing the use of narrowband imaging, which show the superior as compared to white light imaging to show the abnormal bladder cancer lesions. And here is the video, and you can see, and on the left side is use the white light. You can see patches of redness or erythema over the mucosa, but it is hardly see any individual lesions, or sometimes you miss out something. But on the right hand side, you can see by switching to the narrowband imaging, even the most minute or small tiny lesions can be way well shown in the endoscope. So with this accuracy, we can have a way better confidence in diagnosing the bladder cancer and also picking up all the subtle lesions as well. Here is another image. You can see when you when you're moving around, even you can use the narrowband imaging in the environment of the transreferral resection. And when I first used the narrowband imaging, which is the very first generation of NBI, at that time the light source is still very dim, or the light source, the power is not that high. And so even a subtle or small amount of blood in the field will affect your vision. But right now with a way better, I'm not sure what generation, maybe the third generation, I don't know. I lost the count already. But the newer generations of the light source and the narrowband imaging or whatever, so even in the during the CRBT with some blood in the urine or in the medium, you can still maintain a very good visualization. It's just a list of some study in the past that confirmed that the use of the narrowband on the diagnosis of bladder cancers, including improve the detection of the non-muscle invasive bladder cancer, improve the detections of the cancer recurrence, detect the residual cancer in the second TURBT. And also one thing is very important is superior in detecting recurrence in patient after BCG therapy, especially when you, all of us understand that for the patients after BCG therapy, the bladder mucosa is very edematous and very difficult to see. And with the use of NBI, Harry Herr has shown that it helps to detect early recurrence in this group of patients. And because of a better detections, so it shows that increase the relapse-free time of bladder cancer. And there's a collaborative study as well, led by the CORUS, the Clinical Research Office of the Urological Society, involving multiple centers in Asia to look for the narrowband imagings on bladder on patients undergoing TURBT. And just trying to see that if the patients undergoing TURBT, transreferral resection of bladder tumor, if under the use of the white light or narrowband imaging, will this affect their the outcomes of the patient? So as this recruited nearly 1,000 patients over a 3 years period, and we have analyzed a lot of patients, and we found that the operation time in narrowband imaging may be a bit longer, maybe because we need to switch back and forth of a different light source, but actually it's just a switching just a button between the two mode. And we in the narrowband imaging group, we definitely can see more lesion as compared to white light group. And even though when we compare the two groups, means that the white light versus the narrowband imaging, the recurrence-free survival is rather similar on both two groups. But when we really focus on those patients who has a low risk, or means that the earlier stage tumor, less tumor, then we found that there's a advantage in the narrowband imaging group on the recurrence-free survival in those who has a low-risk bladder cancer. And so it may means that we have a more efficiently or effectively clean up or clear up the cancer under the narrowband imaging. So in that conclusions, we even though it's take a bit longer on the time on by using narrowband imaging, but it's or significant can see more bladder tumor in the narrowband imaging environment. And the so in our conclusions, we think that the using narrowband imaging, not just in the diagnostic flexible cystoscopy environment, but also in the transreferral recessions of bladder tumor environment, we can also take this advantage as well. And here is the latest study published in by the Chinese group. They have done a meta-analysis of over 26 studies, totally nearly 4,000 patients in total, trying to compare the diagnostic performance between white light, PDD means that the photo dynamic diagnosis, which is very commonly used in the European country, and also the narrowband imaging. Just a little bit introductions. The PDD means that you need to use the 5-HAL or injections, installation into the bladder, so that to make the tumor visualized under the blue light cystoscopy. So based on this systemic analysis, meta-analysis, the narrowband imaging shows significant diagnostic superior compared with the white light. And also the narrowband imaging has a highest diagnostic odds ratios among all groups. So that I think it is a very good practice, especially if your equipment is equipped with narrowband imaging. Just try to switch to narrowband imaging in every single patient when you are doing the cystoscopy, to look for any subtle which may not be detected by the white light. The second part of the presentation is mainly focused on the bipolar resection. I think Dr. Luqman has given us a very, very good overview on the bipolar technology and the what is the bipolar technology, or how is advantage over monopolar, and also the basic science behind it. And Dr. Cho has also shown us very well on how to use the bipolar technology to do the even a very difficult procedure for many of us, the enucleations of the prostate. And as I think for us, the transurethral surgery is really a bread and butter procedure. And also many a time the patients, especially nowadays, lots of patients really taking anticoagulants or anti-pellet agents. So the bleeding or good hemostasis is also a very big concern in our urology patient. And the quality of resection is also very, very important, especially in the TURBT. When you think about that, in the TURP, and when you do recessions on enucleation, it has a possibly have a higher safety margin as compared to when you do the resection in the bladder, because the bladder is quite thin. And why we use the technology, the bipolar technology, there are multiple potential advantages, including those more effective resections, or even using the vaporization, even though I don't recommend to use the vaporization in bladder cancer, because the histological analysis is so important and critical in the bladder cancer patient or treatments. And there's definitely less cauterization artifact and better hemostasis, a very pinpoint, precise hemostasis instead of all the charring over the mucosa, and decrease the TR syndrome because of use of the saline instead of the glycine, and also reduce the obturator reflex. It is very, 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 very important to emphasize that it is reduce the obturator reflex, but not to completely eliminate the obturative reflex, because we still some patients will still experience obturator reflex. And the so I think that the mechanism we may not need to mention too much, because Dr. Luqman has a very good review. But in general, because of this monopolar versus bipolar, because of more precise conductions of the electricity, you can see that the cauterizations or cutting is more precise, and instead of a very wide area damage to the mucosa, is a very good advantage especially in TURBT. And actually, right now the bipolar technology has been employed or provided by many different companies in nowadays. You can choose what you usually use, but in general, there's as compared to monopolar technology, you have the cauterization or cutting loop. You also need to have a return circuit through your scope, no matter using a separate wire or through the sheath as a return circuit. And especially, as I repeatedly mentioned about the TURBT, the difference as compared to resections of the prostate. And one thing is also very unique is that we need to have a good detrusor muscle sampling in order to get a diagnostic value. Because whether the tumor is muscle invasive or non-muscle invasive, it's so important and critical to the subsequent treatment on the bladder cancer patient. But traditionally, we know that nearly 1/3 of the case have inadequate muscle sampling, likely because the surgeon is not willing or not there to cut deep enough to sample the muscles. And also one potential reason is the cauterization artifact. It just burned out all the things, and even the deepest most layers of the muscle will be burnt using the monopolar energy. So when we employ the bipolar technology, hopefully we can achieve a few things. One is to decrease the TR syndrome, better hemostasis, less obturated jerk, and less charring effect on the tissue. And because of very precise cutting of the diaphragm, so we may increase the muscle sampling rate at the tumor base. Here is one of a sample using the bipolar technology on this bladder tumor. We're also switching to the narrowband imaging so that we can see the edge of the tumor very, very, very well. And here is the bipolar technology. So you can appreciate that even the cutting of the tumor is very precise, instead of really burning too much at the base as compared to monopolar. And also, as I have mentioned before, even with some blood in the urine or during the resection, the visual clarity is still maintained, even we use the narrowband imaging environment. And here is just a few studies mentioning about the comparing the bipolar versus monopolar. The first two is mainly some retrospective study trying to compare the safety, everything. So this is date back from year 2012, and we show that both monopolar and bipolar are safe and effective. And here is also another study from Korea, and comparing the biopsy tissue damage between the monopolar and bipolar. It's also a retrospective study, but then showing that the bipolar technology and monopolar technology are both safe and effective in resection. Here is the another study, and which is we also collaborations in the Endo-Urological Society among us, and trying to compare the monopolar and bipolar transferable resection data. It is just the previous database we've mentioned in this presentation. We use the same data, just trying to look back and to see whether the center use monopolar or bipolar technology, whether it will affect the outcome of the bladder cancer. And so we have to we can analyze around 700 patients who have treated the non-muscle invasive bladder cancer with monopolar versus bipolar TURBT, and they show that there's no significant difference in the post-op bleeding, complication, or tumor recurrence at all. And here's another study that published from my center, and they trying to compare the detrusor muscle sampling rate by using either monopolar versus bipolar in a randomized trial. We have totally recruited around 160 cases, and it's just a simple allocations 1-to-1 ratio. And from the study, we can show that in patients with urothelial cancer, the bipolar TURBT achieve a higher detrusor muscle sampling rate as compared to the monopolar TURBT. In this study, we in the bipolar, we have around 80%, over 80% of sampling as compared to around 67% in the monopolar TURBT. And so it is a trend towards a superior detrusor muscle sampling in a bipolar TURBT group. So it is a very short summaries on this THUēt technology and the monopolar and bipolar. And simply said, the different liquid medium in the bipolar, you can use the normal saline, and the similar kind of a cutting loop design, and you can different, but remember there's a different energy setting as compared to monopolar versus bipolar. And also because of a more snap, clean cut in the bipolar and less cauterization, so we think that the detrusor muscle sampling is also better. And in this present is the end of my presentations, but I just want to additionally mention one thing is that right now for we treating the bladder cancer, we do more and more en bloc resections of bladder tumor. What it means that is right now, as you see that from Professor Cho using the not the TUR or transreferral resection of prostate, he used the enucleation of the prostate. Bladder tumor, we may not be using the resection of the tumor, but we're trying to do the en bloc, means that we cut deep down and try to push and cauterize in a similar mode as what we did in the what we do in the prostate cancer, prostate adenoma, trying to enucleate or en bloc reset the bladder tumor. And in this setting, the use of a bipolar technology is even better as compared to monopolar technologies, because, as I said, you can have a good advantage, take the good advantage by using bipolar technology with this more clean cut, less unnecessary cauterizations or charring, a more precise diaphragm. So I think this is the end of my presentation. Thank you very much.
Thank you. And I would like to invite Dr. Hoàng with the lecture Transurethral Thulium Laser Enucleation of BዓNG Hospital. Please start, Dr. Hoàng.
Yes, thank you for your presentation. I would like to go ahead with my presentation. My presentation is Lithulium Laser Enucleation of the prostate, which is called the THUēt. Do you hear me?
Yeah, we can.
Yes, we can hear.
Dr. Hoàng, please unmute.
Yeah. Do you hear me now? Do you hear me now?
Yes.
Yes.
We know that BPH is a highly frequent disease, which is associated with BPE, LUX, and BPO. So far, we were taught that the open or transurethral removal of the prostate remain the mainstay of the surgical treatment of BPO. Although TURP remain a safe procedure with high success rate, recently laser prostatectomy has become increasingly popular due to the reduced peri and post-op morbidity, short catheterization and hospitalization time, and especially as presented by Dr. Luckman in the guideline of EU, if we have the laser, we can treat the patient with the bleeding disorder or the patient having the anticoagulative drugs. Cannot move. Until now, open prostatectomy and whole lab have shown superior efficacy and durability compared to TURP. But recently in 2005, another modern laser is the Lithulium Laser has entered clinical practice, and since then it has become the most innovative and universally accepted laser armamentarium in urology after the holmium. And we know that the Lithulium Laser is a continuous wave laser with a wavelength of about 2000 nanometer, and the absorption length is about 250 micrometer. About the laser principle, we have to know that the higher the absorption by tissue, the less heat is generated in its deeper layers. So that we know that in Lithulium Laser, it has a higher absorption rate. So the less heat is generated in the surrounding layer, so it can cause less traumatic lesion in the surrounding layer of the tissue. This is a picture of the absorption spectrum for melanin hemoglobin. In this picture, we see that the wavelength of the Lithulium Laser is 2 micrometer, and it is highly absorbed in the water. For the principle in laser, we should know that lasers are divided into 2 groups: the pulse and continuous wave laser. The pulse laser, for example, the holmium laser, when we use this kind of laser, it creates a large steam bubble surrounding the tip of the laser, and it is the large bubble in holmium laser. And if we use the holmium laser for enucleation of the prostate, it's the expanding steam bubble. It will separate the adenoma from the peripheral zone, and coagulation is achieved by the heat within the bubbles. But if we use the Lithulium Laser, it's another laser in terms of the continuous, the mode, continuous wave mode. In this laser, the bubble are much more smaller, and it provides this is the very small bubble between the fiber tip, fiber laser tip, and it can provide the optical contact of the laser radiation into the tissue. And so this kind of laser can allow precise cutting, smoother incision into soft tissue, and which is very useful in urology. And using this laser, we can have the best accuracy, energy efficiency, and minimal collateral damage, as I told you in the previous slide. This is the picture showing the bubbles. In the left hand side is the bubbles when you use the holmium laser, and in the right hand side you see the very small steam bubbles in Lithulium laser, which is a continuous wave mode. There are some nomenclatures for when you use the Lithulium laser for treating the prostate. We have the vaporization, vapor resection, vapor enucleation, and finally the TUYLab. If you listen to the presentation by Dr. Song-Yong Cho, you will see some similarity between the Bpo lab and the TUYLab in terms of using energy to do some resection, some vaporization, some vapor enucleation, and especially some the so-called real mechanical enucleation of the adenoma. But in my presentation, the difference is that we use the Lithulium laser rather than the rather than the bipolar energy, and it is in this table. It is the TUYLab. That means that's the only technique that means the blunt mechanical enucleation and with some support of the laser energy. When you use the Lithulium laser, it is very suitable for the vaporization, vapor resection, and also suitable for vapor enucleation of the prostate. If you perform the vapor enucleation, that means the technique of Lithulium enucleation of the prostate, which is called a TUYLab. In this procedure, we can remove completely the adenoma, combining the blunt mechanical enucleation of the tissue and the laser energy. I will further elaborate in the following slide how to combine this. We have the two principles of enucleating techniques. I mean the true enucleation and the vapor enucleation. In the true anatomical enucleation, you use only the blunt dissection to develop the surgical plane without using any energy. You don't use the bipolar, you don't use the laser, you don't use the energy. You use only the mechanic force to develop the surgical plane. But if you use the vapor enucleation, you use the vaporizing capacity of the laser energy to cut and sear the surface at the same time. And in this picture, you can see above is the so-called retrograde anatomical enucleation. In this case, you use the real anatomical enucleation without using any energy. But from the below, you can see the energy-based retrograde enucleation. That means you combine the anatomical enucleation with some laser energy. And what the difference between these two kinds of enucleation? In experienced surgeon, you can mix these two kinds of enucleation within the procedure, and you as presented by Dr. Song-Yong Cho, he used the bipolar energy, but in this case we use the energy we use is the Lithulium laser. But it's for the experienced surgeon. How about with the beginner? They say the beginner should start with the anatomical enucleation rather than the vapor enucleation. After he is used to the machine, he can move on to the vapor enucleation. and below is a picture of the so-called anatomical enucleation on the left hand side, and the extra anatomical enucleation on the right hand side. In this picture, you can see that if you use the Lithulium Laser for enucleation, you have the TUYបំ. That means you are on the anatomical enucleation side. If you use the Lithulium for vaporization, you use more energy for vaporization of the prostate. That means you move to the extra anatomical enucleation of the adenoma. If you use the holmium laser for enucleation of the prostate, you can move both sides, both directions. You can move to anatomical or extra anatomical enucleation. Similarly, if you use the bipolar, you can be either anatomical or vapor enucleation. It depends on the amount of energy you use when you do an enucleation of the adenoma. What the guidelines say about the laser enucleation. In this slide, you see the recent guideline of the AUA. In the statement 20, it says that the clinician should consider whole lab or two lab. That means the laser enucleation, depending on the expertise with either technique. And it's because it's a prostate size independent option for the treatment of large BPH. That means you can perform an laser enucleation of the adenoma with the same technique and independent of the size of the adenoma. And in this guideline, they say that the whole lab and two lab have similar outcome when compared to the classic therapy for the treatment of symptomatic BPH in terms of IPSS and IPSS quality of life outcomes. And the QUANG at last follow-up after the whole lab and two lab compared to therapy is similar. And the two lab and therapy were similar in the QUANG after 3 months, 12 months, 18 months, even to the 5 years follow-up. And how about the guideline of the EU? In this picture, you can see the guideline of the patient with large BPH treated depending on the size of the adenoma. Small size under 30 ml, medium size 30 to 80 ml, and bigger size more than 80 ml. And it depends on the patient having the anticoagulant or not. And in this picture, you can see we can use the laser or the laser enucleation of the adenoma in case of the patient with the adenoma of the medium to bigger size, or the patient having the anticoagulant or antiplatelet therapy. And it is the so we can have the main indication of the laser or the laser enucleation of the adenoma in case of the medium to bigger size of adenoma, and in case of the patient having the anticoagulation. Some revision of the indication for surgery. According to the guideline, we can have the strong indication for surgery as a recurrent urinary tension, recurrent hematuria, bladder-stenotic renal insufficiency, and the relative indications is the morphological changes in bladder or the upper tract, PVR more than 100 ml, and recurrent UTI, or the patient's willingness for surgery. How about the limitation and risk? When you use the laser or the Lithulium laser for enucleation of the prostate, will depend on the size of the adenoma, as I mentioned in the previous slides of the EAU guideline. You should use the 2-lap or the whole lap laser enucleation in case of medium to bigger size of the adenoma. That means that the adenoma more than 30 ml. If a small adenoma, you should not do the laser enucleation. In that case, you have to use the TURP or the transurethral incision of the prostate in case of the small prostate. So when you use an laser enucleation of the prostate, that means you use the size in independent procedure. That means when you use the, for example, when you use the more classic energy, for example, bipolar, monopolar energy, electrical energy to do a transurethral resection of the prostate, it depends on the size of the adenoma that you will have the different morbidity, the different operating time. But when you use, if you use the laser enucleation, you will find that the bigger, the very big and the big prostate size does not vary very much in the procedure. About the contraindication, if you use laser for vaporization, for enucleation, you can operate on the uncorrected coagulopathy patients, as pointed out in the previous slide of the EAU guidelines. And that is the main advantage of the laser application in this kind of surgery. How about the pre-operative preparation? You can stop the anticoagulant or not. Not compulsory that the patient have to stop the anticoagulant before the surgery, but you have to rule out and treat the UTI. You can use the thrombosis prophylaxis, but I think if you use a laser, the patient will be will sit up very early. I think more early than the classical therapy. So I think when you use the laser, the thrombosis prophylaxis is not really necessary. How about the prophylactic antibiotics? We use the single dose of cephalosporin second generation with a single injection. For the anesthesia, we can use the spinal anesthesia or the general anesthesia. For the instrument, normally we have to have the 3 kind of equipment. This first one is a laser equipment. That means you will have to have the 2 micromet continuous wave lithium laser, yak laser. You can use the classically you can use the Revolix machine by Laser Germany. You have to use 2 levels of energy, the high level of 70 to 90 watt and the 30 watt, the lower energy 30 watt. And I will mention when to use the higher energy and when to use the lower energy later. And you have to use laser fiber of 550 micromet laser made by Laser Germany. Or I will tell you after. We can use the another kind of machine, another kind of laser machine. Secondly, we have to have the endoscopic equipment. This is like the same as in the classical therapy. That means a resectoscope of continuous flow of 26 French, 30-degree length camera. And in this laser procedure, you can, as in the bipolar resection, we use the physiological saline solution as irrigation fluid. And thirdly, you will have to use a modulator because we perform a transurethral, that means endoscopic enucleation of the whole adenoma. So for removing the adenoma, we have to fragment the adenoma into the small pieces. So we have that means we have to use the tissue modulator. And when performing the modulation of the tissue, don't forget to keep the bladder distended to avoid the bladder trauma. And now I would like to move on to the operative technique, step-by-step procedure. The patient is placed in lithotomy position, like in many other transurethral procedure of the lower tract. The urethra is irrigated with sterile gel. We put the 26 receptoscope into the bladder. We put the laser fiber into the working channel of the receptoscope, and we do a cystoscopy to see the spatial landmarks inside the bladder, for example, the urethral orifice. And we can see the bladder neck and the extent of the lobar protrusion, the IPP, and the position of the varus. And now we move to the so-called the 3-lobe technique. Most of the time we follow this kind of technique, 3-lobe technique, because we find it more convenient, more easier, and maybe more safe to do, which has 5 steps. Circumferential incision of the varus, removal of the prostatic median lobe, if it has a median lobe, apical incision of the lateral lobe, removal of the lateral lobe, and finally the modulation. If the adenoma has only 2 lobes, we perform the 2-lobe technique. But if the adenoma has 3 lobes, we perform the 3-lobe techniques. We don't perform the 2-lobe technique in case of a 3-lobe adenoma. So the step 1, we have to make a inverted U incision, close to the varus, using the high energy setting at this stage, and the incision is carried down to the depth of the surgical capsule, as shown in this picture. Step 2, we move to the removal. If exists a median lobe, we have to remove the median lobe first separately, and we perform a bilateral bladder neck incision at the two sides of the median lobes, and the depth of this incision is down to down to the surgical capsule of the adenoma. And then we perform a retrograde enucleation of the median lobe. And at this, when we begin the enucleation, we have to use the low energy, and so we have to switch to the 30-watt energy. And we continue to bluntly shift the median lobe toward the 12 o'clock. And during this mechanical enucleation, we have to do some laser coagulation of perforating vessel at the low level of energy. That means the 30-watt coagulating of the small perforating vessel when performing the mechanical enucleation of the adenoma of the median lobe. And we continue to push the median lobe into to enucleate the median lobe to the bladder neck, and then median lobe is pushed into the bladder. The step 3 is the enucleation, the incision, apical incision of the lateral lobe, we move to the 12 o'clock position, and we make incision using the low energy, low laser energy, and from the incision next to the verruc, we make the two superficial incision into the mucosa toward 4 and 8 o'clock position using the low laser energy, and after that we can see the lateral lobe, and we use the receptoscope to bluntly enucleate the lateral left lobe toward the 2 o'clock position. And in this stage, if we see any small perforating vessel, we can use the energy, low energy laser to coagulate the small vessel. And we will enucleate the entire lateral lobe bluntly and progressively toward the bladder neck. And after that, we will continue to enucleate the whole lateral left lobe to the bladder neck, and we can finally push the entire left lobe into the through the bladder neck into the bladder. And we can use the energy to coagulate some small perforating vessel, and finally we can push on the left lobe to the bladder neck and push the left lobe totally into the bladder. And when we finish the left lobe, we will move on to do exactly the same procedure in the right side to enucleate the right lobe of the adenoma. And the step 5, we use the modulation. Beware that when we do the modulation with the modulator, we have to use the continuous irrigation and a fully extended bladder, and using the modulator, we can fragment the adenoma in the bladder. And after that, we after the modulation, before finishing the procedure, we should make a final inspection of the reception cavity to see if the cavity is smooth. Is there any remnant adenoma? And we can do some additional vaporization or resection, vaporization or enucleation of the small remnant adenoma. And finally, we put a urethral catheter of 12 or 20 or 22 French, and the balloon is inflated, and the balloon is fixed to the fossa using a knot compress. And this urethral catheter, because we use the laser to enucleate the adenoma, so the bleeding is very minimum, and the catheter normally could be removed on the first post-operative day. I have just described the 3-lobe techniques. You can use the 2-lobe techniques. When using this technique, you can enucleate the right lobe together with the median lobe, but we don't prefer this kind of procedure. In the literature, they describe the en bloc technique. They can enucleate the whole adenoma as an en bloc tissue, but I think it's not for this technique is not for the beginner. We present our initial series of our first 30 patients. In this series, we use the laser machine of the Reikin, of the Shanghai Reikin company of China. We use the laser fiber of laser. we use the modulator of Hock company made in China. And for the endoscope, we use the Canstock system. And we perform the 3-lobe technique if the patient has a 3-lobe adenoma. If the patient has only 2 lobes, we use the 2-lobe technique. But if the patient has a 3-lobe, we use the 3-lobe technique rather than the 2-lobe. I show you some of the stages of the procedure performed by me recently. This is the inspection of the posterior urethra. And so, as I told you, we use the 3-lobe technique. So initially we do the enucleation of the median lobe. For enucleation of the median lobe, we have to use the incision at the 5 o'clock and the 7 o'clock deeply into the until we find the surgical capsule of the adenoma. And the incision is carried out from the bladder neck to the near the varus. Sorry. After incision of the 7 and 5 o'clock incision, we will move to the mechanical enucleation of the median lobe, starting from 6 o'clock from the 6 o'clock to 12 o'clock. To enucleate the median lobe. When enucleating the adenoma, if you see the small capsule perforating vessel, you can use the energy to coagulate this small vessel. But most of the time, you use the resectoscope to mechanically enucleate the adenoma rather than the laser energy. And but when you are the beginner, most of the time you have to use more energy. But when you become more experienced, I think you will use less and less the laser energy, and most of the time you use the big of the resectoscope to mechanically enucleate the adenoma. And sometimes we have to combine these two, the energy and the mechanical enucleation. And finally, we can push the middle lobe into the bladder, and you can see the surgical capsule of the adenoma. And this is the incision vaporization at the 12 o'clock. After this, we will move on to the enucleation of the left lobe. Sorry. And this is the enucleation of the left lobe using the same principle when you use the enucleation of the middle lobe. And you see we use the low level energy to coagulate some small capsule perforating vessel when enucleating the left lobe. And if you push the resector scope into the right plane, you will see very clearly the capsule, the surgical capsule adenoma, and we have just finished the enucleation of the left lobe. So we will move to the right lobe, exactly the same maneuver as on the left one. And after that, we use the modulator to modulate the adenoma. And for this initial series, you see that the prostate, the volume of the prostate is quite big. Is the medium is about 92 gram. It means that the very big prostate. And the smaller one is the 60, and the biggest is the 240. With the operating time about quite quick, about 65 minutes, with the enucleation time about 57 minutes, modulation time about 7 minutes. And you see most of the cases, about half of the cases, we have the operating time less than 1 hour. And the drop of the hemoglobin, hematocrit, and serum natrium, serum sodium is, you can see that the very small changes of post-op, hemoglobin, hematocrit, and sodium in comparison to the pre-op. Very small changes in these parameters. And the catheter time is very short, less than 2 days. And the hospitalization time and the most of the catheter time is always less than 3 days. And the hospitalization time is about not more than 3 days. And you see 100% of the patient has the hospitalization less than 3 days. When I recall to the TURP patient, I remember that we have the mean hospitalization time maybe twice than that. And this is the amelioration of the IPSS score and quality of life score in 1 month post-op. You see the IPS score decrease clearly, and the quality of life score increases very clearly in 1 month post-op in comparison to pre-operative. And this is the pre-operative and versus post-operative IPSS and quality of life in terms of 1 month post-op and 3 month post-op compared to pre-op. You see very clear amelioration of the symptom and a very good increase of the quality of life. And we see the QMAC increases. The QMAX can normalize in 1 month post-op and is stable in 3 month post-op, and the PVR post-operative PVR decreases very clearly. For this initial series, we have the very mild post-op complication. For the early complications, we have the post-op UTI in 10% and treated with the treatment antibiotics, and the patient can be discharged in day 3 post-op. That means a very mild urinary infection. Urinary retention in 4 cases out of 30, and the treatment is just insertion of the catheter for several days, and when remove the catheter, the patient can have the normal urination. 2 cases we have the transition urinary incontinence, and it was resolved spontaneously after 1 week. And for late complication, we only one stenosis of urethral meatus, which was resolved with the simple meatotomy. So we see that in this initial series, we have the very moderate or even very mild complications. For the competitors, you know that it depends on your institution. You can have the laser, you can have the surgical electric energy, so you can use the laser. If you have the whole lab, you can perform the laser holmium laser enucleation. If you don't have the laser, you can use the bipolar as presented by Dr. Song-Yong Cho previously. So if you have the thulium, you can use the thulium and the TULAP. So for the conclusion, I would like to say that TULAP has evolved as one of the standard techniques of transurethral anatomical endoscopic enucleation of the prostate. It has 2 principles: blunt anatomical dissection and the using of the energy to help the enucleation, to have the enucleation process. And the TULAP offer the advantages of complete removal of prostatic adenoma, similar to open surgery, but with the advantage of minimally invasive surgery. And growing evidence shows that TULAP has a valid alternative for the treatment of BPO and has been acknowledged by the guidelines on the management of male lux. So the TULAP is evolving a very good option for transurethral enucleation of the adenoma. So the training of this kind of technique is a need. Thank you for your attention.
Thank you, Dr. Hoàng, for your presentation. Now we have a lot of questions. And if we have no time, we will share that to the next time. The question for Dr. Hoàng is, Dr. Hoàng, can you tell me about the advantage and inconvenience of laser in comparison with bipolar?
I think the shown disadvantage of laser, generally speaking, and the thulium laser specifically speaking, is the cost. For performing this procedure, we have to ask the company to help to support the cost. Otherwise, our patient cannot afford these cost of the laser procedure. And normally the patient in our center, we can use only the bipolar enucleation of the prostate, which is much cheaper. It's I think it's only the only disadvantage of the laser is the cost. And in my experience, the rest is only the advantages when you use the laser. As I remember Dr. Song-Yong Cho said, that I totally agree. When you have a big lateral lobes, using the bipolar energy with the system of the bipolar energy, you will sometimes you will be easily stuck in the middle part of the lateral lobe because when you use the surgical electric system, the system is quite big, and if the adenoma is big, you cannot move ahead. Otherwise, on the contrary, if you use the laser, you can move forward very easily despite of the size of the adenoma. In my experience, I performed this with one of my younger urologists, and we found that 60-gram adenoma is quite similar as the 100-gram adenoma in terms of bleeding, in terms of difficulty of the procedure, in terms of operative time. So we can feel that this procedure is really a prostate size independent procedure. So for conclusion, except for the cost, I think the laser has, especially the thulium laser, has the best advantage, and I think it's a wonderful wonderful tool for performing a transurethral enucleation of the prostate. It's my own experience.
Thank you, Dr. Hoàng. And now, Dr. Cho, you have one question.
Yes.
Dr. Cho, what's the learning curve of TUEP and HOLAP?
I think the learning curve of bipolar enucleation is much shorter than compared to the holmium laser, and I think I have a bias because I tried holmium enucleation first for about 3 years, and then I moved to the bipolar because I think the holmium laser enucleation can have a minor, I don't know, anyways, a minor disadvantage because the laser is not so good at bleeding control, and bipolar has the utmost capacity of bleeding control. So I think the bipolar enucleation is very, very helpful for controlling the vessels. So recently, my preference is bipolar, but the holmium, if you want to do holmium laser, then the incision and the speed is very good, and then you can get some high speed enucleation procedure, but you may need some longer coagulation time. So, but this issue is about how we are familiar with the enucleation plane and how much we can get some experience of masters or some good surgeons around us about the enucleation procedure. So yeah, in many cases it can be case by case, but basically I think that generally speaking, the learning curve of bipolar can be shorter than holmium laser enucleation.
Thank you, Dr. Cho.
Thank you.
Dr. Hakim, there is one question for you. Which do you prefer, bipolar or monopolar, in case of bladder neck sclerosis?
Bladder neck stenosis, you mean?
Yeah. The one you want to do the transurethral incision.
Okay, the bladder neck incision. Of course, since the invention of bipolar, I try to do everything using bipolar. And the reason is, I have explained in my earlier slides that it has many advantages to monopolar, except the bleeding ability, the coagulating ability of bleeding. So bladder neck incision is a very simple procedure. I would say bipolar. I prefer more bipolar because to prevent a larger area of further damage in the surrounding area that I'm going to incise, and this will lead to future stenosis. I think bipolar has more advantage than monopolar in this case. Thank you, Professor Finn. I think he's not here with us.
He must be here. Okay.
There is one question for all of you, and if possible, every one will give his thought on this question. That to prevent bladder perforation in case of the bladder tumor is on the lateral wall and near the nerve. So how you can give us the experience to prevent the perforation or not?
I think in the situations like this, bipolar technologies definitely have an advantage, which can decrease around 50% of the obturator jerk, even at the lateral position. Second is the trying to prevent overfilling of the bladder, so that the bladder is less distended and less likely to have perforation. And then it is how you deliver the energy, trying to use a shorter pulse instead of just step hard into the paddle. And so at any time, if you see any reflex, you can still stop the cauterizations or cutting. And also communicate with your anesthetist and change to general anesthesia or with the muscle relaxant. And even some of the people may think about using some sort of nerve block, but I don't personally have much of the experience of nerve block, but mainly on general anesthesia with muscle relaxants may help the situation.
Dr. Hakim, how about your opinion?
Yeah, basically, I agree with Eddie, and I just want to add two things. In my hospital, particularly for multifocal bladder tumors, the block will always be done by anesthetists. So it is very rare that we experience the jerking of the legs because we touch the obturator nerve. That's one thing. Secondly, I just want to add the information, the explanation of Eddie, that probably the technique of resecting layer by layer in a stepwise manner is much wiser than completely to resect the tumor until the base. This way, we will see in which layer are we, or is it too deep, or we can move further or not. This was also my experience when I was a resident. I tried to resect the whole tumor, including the base of the tumor, and perforation occurs. So step by step, in a stepwise manner, layer by layer, and then we can avoid the perforation. Thank you very much.
Thank you. And how about you, Dr. Cho?
Normally, I don't normally do the QLB in my hospital. So basically, but bladder filling is a critical factor. I know. Yeah, just
and
like other people. Mm-hmm.
Yeah, thank you. And how about you?
I personally, in case of QRBT, to avoid the obturator nerve jerk, I would order, as I agree, the same idea of the Dr. Eddie Chan and Dr. Hakim Lukman. I will order the bipolar system, bipolar surgical electrical system, and recently, most of the time, when possible, I perform the en bloc tumor resection with interrupted energy using an interrupted moving of the loop. most of the time, I don't ask the anesthetist to perform a block of the a nerve block, regional nerve block. Most of the time, I manage myself using the bipolar system, performing the end block resection of the tumor, because I find it a very wise strategy to remove the bladder tumor, because we can go by beneath the tumor, and we can make an interrupted cutting using interrupted energy to move very step by step in a stepwise procedure. And most of the time, I have no problem of this kind of incompetent.
Yeah, thank you. Totally agree with all of you. But if possible, in some service, we can use laser to avoid the nerve tract. And Dr. Wang, there is one question for you. Dear Professor Huang, while doing TULAP in clinical practice, have you ever converted to open a TURP due to severe bleeding or in some other difficult status?
Yes, it's a very good question. At the very initial 1 or 2 cases, I was not used to the laser system. But I have to mention that before performing the TULAP, I have some experience of the bipolar. So I know what is the transurethral enucleation of the adenoma by using the bipolar previously. But when I moved to the TULAP, I was afraid, and I asked the assistant to prepare for me a system of bipolar system for the very first cases. And I remember that the first cases I used it. Only at the very initial cases, I used the electrical system together with the TULAP. And from the second cases, I didn't use it anymore. Because I think maybe I have some experience, maybe because that I have some experience of the bipolar previously.
We have one more question, and we will answer this question. And if there is another question, we will share it to another next time. This question is for all of us that. Beside the big tumor, how about the efficacies of bipolar in comparison with laser? Is it the same? Dr. Chan, please.
Trying to compare with laser, right?
Yeah.
I think for back tumors, I think the resections is way better than using the laser. I think it is for easy to complete the tumor, especially if it's big or wide base. And I myself don't have much experience on the laser, frankly speaking, because I think right now they use a recession technology, or even right now change to the on-block recession, and still doing the resectoscope is quite versatile and very useful.
Thank you. And how about you, Dr. Hakim?
Yeah, thank you. I think if all of you agree that the suitable answer will be the surgeon preference and skills, I guess. For instance, when I was a resident, I was taught that TURP can be done in a prostate size less than 80. But then by time, we will individually realize that we can resect the tumor up to 100 or 120. This is one thing. And secondly, I think there is a lot of clinical trials that have been done and based from the retrospective study or head-to-head comparison perspective, and with various endpoint results. But if we see the guideline, as I've mentioned previously, there are only 3 standard of cares for big prostate size more than 80. That was open prostatectomy, HoLEP, and bipolar enucleation. So if you want to summarize all the clinical evidence up to 2020, these 3 are the standard of care, I guess. But of course, again, it depends on the surgeon's skills. Thank you very much.
Thank you. And how about you, Dr. Cho?
Yes, in my case, yeah, during all my experience, the cutoff size can be 80 to 100, but recently, for example, 2 days ago, my inoculation time for 135 gram with bipolar inoculation was only 45 minutes, and I think the cutoff limitation can be expanded to larger prostate size. And in my recently, I am doing the robotic simple prostatectomy if the prostate size is bigger than 150 or close to 200. So recently the robotic prostatectomy can be available for big size prostate, and maybe if the laser efficiency or some the efficiency of energy modality is increased, then we can have more options to do the enucleation procedures. So yeah, we need to validate the cost effectiveness according to the technology development.
And how about you, Dr. Hoàng?
I repeat, I always prefer the laser, but you know that in Vietnam and in at Benign Hospital, the laser treatment is not very so popular because of the cost. And you know that in our hospital, the holmium laser for stone treatment is more common. Most of the time we use the holmium laser. We have a 3 system of holmium laser for stone fragmentation in ureteroscopy, in FURS, in mini PCNL. Most of the time we use the laser, the holmium laser for stone. But so far in Vietnam or in our institution, the continuous wave laser is not very popular. We have only 1 system of holmium laser for the whole lab, but the machine was not good. It was off and on. And for the laser Lithulium machine, we don't have at all. We asked the company to support the patient for our initial limited number of patients. When I use the bipolar for the resection or enucleation, I find that the procedure varies according to the size of the adenoma. That means that if in case of a bigger adenoma, I will have problem, and the endoscopic vision is not very not very clear because of the hemorrhage during the enucleation, during the vaporization, during the resection, using the bipolar energy. But in contrast, as I told you, when using the laser, I see that a 100 gram adenoma is quite similar as a 60 gram adenoma in terms of the hemorrhage, in terms of the operative time, in terms of the difficulty of the procedure. So I'm very keen on the technology, but I think the laser is different. Where are you?
Oh, okay.
I don't see you anymore.
Sorry, so sorry. Yeah. The time is up, and before finishing the webinar, I would like to thank all the speakers, Dr. Hoàng, Dr. Hakim, Dr. Cho, Dr. Chen, and we appreciate your collaboration. And we hope that in the next time we will have many more webinar, and the other question will be shared until next time. And I finish that, and I want to tell some talk to our attendee. Các anh chị thân mến, bây giờ là chấm dứt cái chương trình thì yêu cầu các anh chị hãy làm post test đặng có cái CME và cái đi theo cái đường link như trên cái màn hình, và sau một ngày thì tất cả những cái đường link này sẽ bị xóa, và 20 cái vị nào đã gửi về cái post test trước thì sẽ nhận được CME miễn phí. Xin cảm ơn. Bye bye everyone. See you next time.
Thank you. Bye bye. See you.
Bye. Thank you.
Thì